All right, so the skeletal system, our bones. A lot of times we probably think of our bones as something that is static, like it's just constructed and that's the end of it. But our bones are constantly remodeling. They are constantly communicating with our bloodstream and our nervous system and our muscles. They are constantly, doing things. So that's what we're going to talk about today. We're going to talk about bone growth and remodeling and what happens if you fracture a bone and how does that heal. And we're going to talk about the minerals that your bones contain and how hormones regulate your bone density and all kinds of good stuff. So first of all, there are two types of bone growth. There is interstitial, and that is when your bone increases in length. And we did talk about this a little bit in the intro. This is where it's really the result of a cartilage growth within the epithelial plate. And we know that when that epithelial plate closes, the bone is no longer able to get longer. Remember, and then you see an epithelial line, which you would see in an older adult. Okay? And then there is also apophyseal growth. And this is where bones actually increase in the width. And this happens throughout your life. So what actually happens is you can kind of think of it as like a circle or like a band around the shaft of the bone. Okay? And it basically just keeps adding more and more bone tissue there. So it's basically just depositing new bone on the surface of the shaft. Osteoblasts on the deep side of the periosteum then just continually are depositing this osteoid tissue. And then they become trapped and they calcify, and all of a sudden you have more bone matter. Okay, and it happens, like a circle around the bone, like a band. And you have bone remodeling that's constantly happening throughout your life, about 10% per each year. And this means that you might not know this, but you could have a microfracture and your bone is constantly repairing. It's releasing minerals into the blood and reshaping bones in response to use and disuse. And there is something called Wolff's Law of Bone. And this has to deal with basically the architecture of a bone is determined by the mechanical stresses placed on it and the bone's adaptability basically to withstand those stresses. So, like I've already said, your bone is in constant flux, and depending on how much you work out and what your activity level is, or how much stress, mechanical stress you may put on your bones, that is going to dictate how your bones take care of themselves, or basically, reconstruct themselves, remodel themselves. So we remember that osteoblasts are the bone forming cells and osteoclasts are the bone dissolving cells. And these two cells are constantly working together and against each other to remodel our bones and keep them strong and able to do what they need to do, which, is a lot. Carry us around, really. Okay, physiology of osseous tissue. A mature bone remains a metabolically active organ. We need to remember that. And we need to remember that it is in constant growth and remodeling. And it exerts a profound influence over the rest of our body by exchanging minerals with tissue fluid. What that means is if there is a disruption in our bodies and our calcium levels fluctuate, your skeleton will come into play and it will talk to the other systems and figure out where we need more calcium or where we need less. And this happens through the blood, okay? Because our nervous and our muscular systems rely on calcium. So if you are low on calcium, the calcium might be taken from your bones. So, mineral deposition or mineralization. This is a crystallization process in which calcium phosphate and other ions are taken from the blood plasma and deposited in the bone tissue. We know that osteoblasts produce collagen fibers that spiral the length of the osteon. We know that the fibers become encrusted with minerals that harden the matrix. So you have a compound of calcium and phosphate, hydroxyapatite, which is from the blood plasma and can become deposited along these fibers. The calcium and phosphate ion concentration must reach a critical value called the solubility product for crystal formation to occur. So that's the checkpoint. Most of your tissues have inhibitors to prevent this so that they do not become calcified. We don't want calcium deposits happening anywhere other than the bone, right? Because that can cause a problem. Osteoblasts are able to neutralize these inhibitors and allow salts to precipitate in the bone matrix. First, there are a few crystals called seed crystals, and then they attract more calcium and phosphate from the solution, and there it basically builds upon itself. As I mentioned, you do not want what's called abnormal calcification. You don't want calcium deposits in other parts of your body, but it can happen in your lungs, your brain, your eyes, your muscles, tendons, or arteries. And this would cause a problem, right? And a calculus is what is called a calcified mass in any otherwise soft tissue, such as a lung. Then we have mineral resorption. This is the process of dissolving bone and releasing minerals into the blood. So this is where the osteoclasts come into performance. They can actually break down your bone and release the items in your bone back into your blood. And this is done in with a couple of different helpers, if you will. Hydrogen pumps in your membranes secrete hydrogen into the space between the osteoclasts and the bone surface. You can have chloride ions that are then followed by an electrical attraction. Hydrochloric acid, which has a pH of 4, also can dissolve bone minerals. And you can have acid phosphatase. Remember that ACE denotes an enzyme, and this enzyme will digest collagen. If you've ever had braces, or you've known someone that has braces, you might think, how is that working? Or maybe you haven't. But basically it is repositioning your teeth, right? If you have, I had an overbite as a kid and I had braces. And although my teeth are not perfect now, they are better. And that is because my teeth have actually moved. And that is due to osteoclasts and osteoblasts working together to move those teeth in the bone. They're breaking it down, they're rebuilding, and it's through the pressure of the braces that this activity is performed. All right, as I mentioned, we want our calcium to be at the correct level, okay? And if it's not, our body has an issue. So, calcium and phosphate are used for much more than just bone structure. As we know, phosphate is a component of DNA, RNA, ATP, it's in phospholipids, and it works as a pH buffer. Calcium is needed for neural communication. We see it in a muscle contraction. It is in blood clotting and in exocytosis. Minerals are deposited in the skeleton and withdrawn when they are needed for other purposes. You have about 1,100 grams of calcium in an adult body. Now, 99% of that is in the skeleton, but it is exchanged throughout, your lifetime into the blood. So here it says 18% of an adult skeleton is exchanged with your blood each year. I mean, that's almost a fifth. Okay, and then we're given some normal calcium concentration in blood plasma levels. And if those levels are deviated, you can become blood calcium deficient, or you can have a blood calcium excess. So hypocalcemia is when you have a blood calcium deficiency. This causes excess excitability of muscles. It can cause tremors, spasms, or tetany. And tetany is basically when your muscle locks and it does not have the ability to relax. And this is happening because sodium is entering the cells too easily and then is exciting the nerves and muscles. If we have a blood calcium excess, that can cause the sodium channels to be less responsive and nerve and muscles less excitable than normal, which would then be the opposite, which would be a sluggish reflex or a depression of the reflex. Okay, so hyper is rare. Hypo has a wide variety of causes. This is much more common. So this could be caused by a vitamin D deficiency. It could be if you've had diarrhea for a long time where you lose a lot of fluid, thyroid tumors, an underactive parathyroid. It could be due to being pregnant or lactating, or it could be due to an accidental removal of your parathyroid glands, which sometimes unfortunately can happen during thyroid surgery. So calcium homeostasis depends on a balance between your dietary intake, your urinary and fecal losses, and the exchanges that are happening between your bone tissues. And it is regulated by 3 hormones: calcitriol, calcitonin, and the parathyroid hormone. So, calcitriol is activated vitamin D, and it is a form of vitamin D produced by the sequential action of the skin, liver, and kidneys. So it is a process that happens. So basically, we use the sunlight, right? You know, vitamin D synthesis deals with the sun. And that is because your epidermal keratinocytes can use the UV radiation and convert it to a steroid, which is basically 7-dehydrocholesterol, which then turns into a previtamin D3. The liver then adds a hydroxyl group to this and converts it to calcitidol. The kidneys, the dol, because of 2, the kidneys then add another hydroxyl group, converting that then to calcitriol, which is the most active form of vitamin D. You can also get vitamin D from fortified milk. Calcitriol behaves as a hormone that raises our blood calcium concentration. It does this by increasing the calcium absorption by the small intestine and increasing the calcium reabsorption from the skeleton. Because it can increase the stem cell differentiation into osteoclasts, which would then work to liberate the calcium and phosphate from bone. It also can promote kidney reabsorption of calcium ions, so less would be lost through urine. This is necessary for bone deposition, and we need adequate calcium and phosphate within our bones, right? Abnormal softness of the bones would cause something called rickets, which we see in children often if they are malnourished. And osteomalacia, which is in adults that have an inadequate amount of vitamin D. Calcitonin. It is secreted by the C cells, or what are called clear cells, of the thyroid gland when calcium concentration rises too high. And it lowers the blood calcium concentration in two different ways. First, it can inhibit the osteoclasts, which would reduce osteoclast activity by as much as 70%, which would mean that less calcium would be basically being liberated from the bones, right? If there aren't osteoclasts, the bones aren't getting broken down. And it can promote osteoclasts. Calcitonin. This is secreted by the C cells, the clear cells of the thyroid, and it is called upon when the calcium concentration rises too high. And it basically lowers the blood calcium concentration in two different ways. It will inhibit osteoclasts and stimulate osteoblasts. If we have osteoclast being inhibited, which it can be as much as 70%, we then don't have these osteoclasts breaking down the bone and liberating that calcium, right? But on the flip then, when we have more osteoblasts coming into play, they will start depositing calcium into the skeleton, taking the calcium from the blood, putting it back into the bone. It's a very important factor in children, but not as much in adults. And that is because osteoclasts are more active in children due to a faster remodeling activity phase. And deficiency does not cause a disease in adults, whereas in children it could be a problem. It does, however, reduce bone loss in women during pregnancy and lactation. Then we have our parathyroid hormone. This is secreted by the parathyroid glands, which adhere to the posterior surface of the thyroid gland. PTH is released with low calcium blood levels. It raises the calcium blood level in 4 ways. It can bind to receptors on osteoblasts, stimulating them to secrete RANKL, which raises the osteoclast population. It promotes calcium reabsorption by the kidneys so that there is less lost in the urine. It promotes the final step of calcitriol synthesis in the kidneys, enhancing calcium raising effect by calcitriol. And lastly, it inhibits collagen synthesis by osteoblasts, inhibiting bone deposition. Sporadic injection or secretion of low levels of PTH causes bone deposition and can cause increase in bone mass. We also need the phosphate in our body to be regulated and to be correct. So an average adult has 500 to 800 grams of phosphorus. 85 to 90% of that is found in the bones. We're given some levels of our normal plasma concentration. And it occurs in 2 principal forms: monohydrogen and dihydrogen phosphate ions. Phosphate levels are not regulated as tightly as calcium levels, and that is because there are no immediate functional disorders. Calcitriol promotes its its absorption by the small intestine and promotes bone deposition. PTH lowers blood phosphate level by promoting its urinary excretion. So the other two kind of keep, calcitriol and the PTH kind of keep your phosphate levels in check. There are also some other minor things or lesser things that affect bones as well. There are at least 20 or more hormones, vitamins, and growth factors that can also affect our bone tissue. We see rapid bone growth during puberty and adolescence, right, when we're growing. We have surges of growth hormone, estrogen, and testosterone, and all those things can promote ossification. These hormones can stimulate the multiplication of osteogenic cells, the matrix deposition by osteoblasts, and chondrocyte manipulation and heterotrophy in metaphysis. Girls grow faster than boys and reach full height earlier. And this is due to estrogen having a stronger effect than testosterone on bone growth. But males usually grow for a longer time and in the end are usually taller. Anabolic steroids cause growth to stop. And this is due to the epithelial plate closing prematurely. And it usually results in abnormal short adult stature. All right, let's talk about what happens if we fracture a bone. Most people have probably fractured or broken a bone in their lifetime, and it has probably healed. So how is that happening? Well, first of all, there are a couple different types of fractures. So there is a stress fracture, and this is a break caused by abnormal trauma to a bone. Maybe a fall, playing a sport, being in the military, but it's like a force trauma. Then there is pathological fracture, and this is a break in a bone weakened by some other disease, maybe by bone cancer or osteoporosis, and it's usually, you wouldn't see this type of fracture in a healthy bone, but because the bone isn't healthy, the stress was able to break it. Fractures are classified by structural characteristics, meaning the direction of the fracture line, whether there is a break in the skin, and if there are multiple pieces. So here is a picture. This first one is showing a non-displaced where you can actually see the fracture, but the bone hasn't moved. And then you have two other ones, and it looks like in both of those you do see displacement. And again, there's several different names according to how the bone looks and what has happened, and this is how doctors differentiate what kind of fracture or break you might have through an X-ray, right? So then you get a cast, or you get a sling maybe, or a wrap, right? Depending on where it is and what has happened. And hopefully you start healing. And normally, if there aren't any problems, a fracture will heal in about 8 to 12 weeks. Now, this does take longer as we get older, because as we know, our bodies kind of slow down. So, just takes more time. But there are 4 main phases that we see in the healing of a bone fracture. The first one is the fracture hematoma and the granulation tissue. So what happens is basically there is some bleeding of a broken bone that forms a clot. This is called the fracture hematoma. The blood capillaries, the fibroblasts, the macrophages, the osteoclasts, and the osteogenic cells will invade this clot, which then forms granulation tissue, which is a soft, fibrous mass produced by capillary and cellular invasion after about 48 hours of the injury. You then have a soft callus formation. This is formed by fibroblasts and chondroblasts depositing collagen and fibrocartilage into the granulation tissue. This is then converted to a hard callus, where we see osteoblasts produce a bony collar in about 6 weeks, and that is called the hard callus. It is cemented to the dead bone around the injury site and acts as a temporary splint to join broken ends together. 4 to 6 weeks for this to actually form, and usually this is when we have to have that area immobilized so that this can actually take place correctly. Then you have continued bone remodeling. This hard callus can persist for 3 to 4 months, and then we see the osteoclast dissolving the fragments of the broken bone, and we see osteoclasts depositing spongy bone to bridge the gap between the broken ends, and it slowly transforms into compact bone, right? And then hopefully you are healed. So here are some pictures and the words again of what I just said: your hematoma, your soft callus, your hard callus, and your bone remodeling stage. The younger you are, the better the chance to probably fully recover, right? So there are different treatments of fractures, again, depending on what kind of fracture it is and your health status. There is a closed reduction, which is a procedure in which the bone fragments are manipulated into their normal positions without surgery. There is an open reduction, which does involve surgical exposure of the bone and the use of plates or screws or pins to basically realign and hold those fragments together. You may have a cast, which is, just to kind of stabilize and immobilize the healing bone. You could have traction, which is used to treat fractures like in the femur of a child, which then will align the bone fragments by overriding force of the strong thigh muscles. Again, depending on your age, your health status, and what exactly the fracture is going to determine what kind of treatment you would have. So traction does take a long time, and you're confined to bed. It's not usually used on elderly people because depending on, again, your age, you may need to get moving as quickly as possible after, something happens. So it says here, hip fractures are usually pinned in the elderly. And early walking is encouraged because you want that blood circulation to get going so that it can aid in the healing. So a lot of factors really play into the treatment you may receive for a fracture. Electrical stimulation could be used, and that will accelerate repair, and it would suppress the effects of the parathyroid hormone. And then there are orthopedics, which is the branch of medicine that deals with prevention and the corrections of injuries and disorders of bones, joints, and muscles. So you may have to go see an orthopedic surgeon or doctor, and they would then determine what the line of treatment, what the best line of treatment would be for you. Here's a picture I put in just to show you. Depending on how bad it is, you could have many screws or pins or plates put into your body to kind of hold it together. And then we're going to end with osteoporosis. And this is the most common bone disease. and it is a severe loss of bone density. Bone loss mass, bones lose mass and become brittle due to the loss of organic matrix and minerals. And this affects spongy bone the most, since it is the most metabolically active. And this means that the hips and the wrists and the vertebrae column become kind of subject to these pathological fractures, meaning as we age, our bones get more brittle, and we can see breaks in these bones that you wouldn't normally see in a young, healthy person. Kyphosis is what's called widow's hump, and that's an actual deformity of the spine in the vertebrae, and it's kind of, if you see an older person that's almost looks hunched over, that could be this, and that is due to a bone loss in the vertebrae column. And then, we start to see other complications with the loss of mobility, which, could be pneumonia or a thrombosis, which remember was like a moving blood clot. So postmenopausal white women are at the greatest risk for osteoporosis. So basically we begin to lose bone mass as early as 35 years of age, and by 70, we've lost 30% of our bone mass. I say we as in me, because I am over 35. And things that, play a role in this are our race, our age, our gender, whether we smoke, if we have diabetes, what our diet is. This is so important to eat well your whole life, because as we go through all these lectures, we learn how every mineral and nutrient plays a role, right? So everything has its place. Estrogen maintains the density in both sexes and inhibits resorption by osteoclasts. The testes and adrenals produce estrogen in men. In women, we see that rapid bone loss after menopause, since estrogen blood level drops below this 30 nanograms per milliliter. So because of the changes a woman goes through after menopause, we see a greater loss of bone. So osteoporosis is common in young female athletes with low body fat, causing them to stop ovulating and ovarian estrogen secretion to be low. So that is kind of an extreme situation, but yes, if you are super physically fit and you do not have your period, you are not menstruating monthly, some of those hormones may not be as active in your system and could cause problems with your bones. There are some treatments. You can get estrogen replacement therapy, which could maybe slow the bone resorption, but that does increase breast cancer, stroke, and heart disease. There are some drugs that could actually destroy osteoclasts, which would obviously stop the bones from being dissolved. And same with, you could have parathyroid hormone. You could be given that, which would slow the bone loss if it was given as a daily injection. But the best treatment is prevention, meaning take care of yourself, exercise, and eat right between 25 to 40, because that's your go time. So really take care of your body, because after 40, it's harder to be healthy and to take care of ourselves. So on that very positive note, that is the end of our lecture. Lots of information. Hope you enjoyed it. Let me know if you have any questions.